Assalamualaikum and good day. My name is Dr. Mardiana Abdulaziz from the Department of Pathology, and this is part 1 of the lecture Valvular Heart Diseases, Rheumatic Fever and Rheumatic Heart Disease. So for this part of the lecture, at the end of it, you should be able to describe the etiology, pathogenesis, clinical manifestations and complications of valvular heart diseases, specifically focusing on degenerative and valvular vegetations. They are the two learning outcomes we will cover in part 2 of the lecture. And in terms of skills, at the end of this part of the lecture, you should be able to identify the gross morphology of valve vegetation in bacterial endocarditis. The morphological features of acute and chronic rheumatic heart disease will be covered in part 2. So let's start with the valvular heart diseases. So as you know, there are 4 cardiac valves. The mitral valve is located in between the left atrium and the left ventricle, and the aortic valve is located in between the left ventricle and the outflow tract into the aorta. In the right side of the heart, you have a tricuspid valve in between right atrium and the right ventricle, and pulmonary valve in between the right ventricle and the pulmonary trunk. And as you know, the main function of the cardiac valves is to make sure that the blood flows in one direction and one direction only. Cardiac valvular abnormalities may take the form of either stenosis or insufficiency. Stenosis refers to failure of the valve to open completely, therefore resulting in obstruction to forward flow. Insufficiency is also known as regurgitation or incompetence. It is failure of the valve to close completely, and that results in regurgitation or backflow of blood into the chamber in which it originated from. So let's compare the differences between the two just briefly. As an introduction, you can see here a normally open valve should be widely patent with a large, complete opening of the orifice, allowing blood to flow freely from one chamber to another, or from the chamber into the aorta or the pulmonary trunk. But in stenosis, what happens is that the valve leaflets or cusps are unable to open properly. Therefore, the orifice becomes extremely narrowed, causing a reduction in blood flow. In comparison, regurgitation occurs when the valve fails to close normally. A valve that can close normally will not allow any sort of leakage of blood through, because it is completely sealed. So the cusps or the leaflets will be completely sealed. In the setting of valvular insufficiency or regurgitation, the valve is unable to close properly. So there will be residual opening in the orifice that allows blood to regurgitate back into the chamber in which it originated from. Okay, so this is regurgitation. So an example of that, where the blood actually goes back into the chamber where it originated from, whereas in stenosis it results in a reduction in the flow of blood across that valve orifice. Let's have a quick look at another short video to explain the differences between stenosis and insufficiency.
Heart valve disease is any condition that disrupts the proper function of the valve. There are 4 valves in the heart that help keep blood flowing in a forward direction as the chambers of the heart fill and contract. Normal heart valves open fully to allow blood to flow in a forward direction through the heart, and close tightly to prevent blood from flowing backward. There are 2 general types of valve disease. If the valve does not open properly, the forward flow of blood is restricted. This is called stenosis. If the valve fails to close properly, backward flow is not prevented when the heart contracts. This is called regurgitation or insufficiency.
So valvular heart disease may be either congenital or acquired. The most common congenital abnormality of the cardiac valves is bicuspid aortic valve. In this condition, there are only two cusps instead of three. In general, there are no problems in early life, but these valves are more prone to degenerative calcifications and they tend to give rise to aortic stenosis much earlier compared to individuals with normal aortic valves. On the other hand, acquired valvular diseases has a much more diverse cause. There are multiple causes and etiologies for acquired valvular diseases, and as you can see depicted in this table here, which is taken from Robbins' Basic Pathology, the table highlights multiple etiologies for mitral and aortic valve diseases, specifically mitral and aortic stenosis, as well as mitral and aortic regurgitation. Recurring theme that you can see in several of these conditions are rheumatic heart disease, which is an important cause for acquired valvular diseases, and we will discuss rheumatic heart disease specifically in part 2 of the lecture. Some of the causes of acquired valvular diseases include senile or aging calcific aortic stenosis. Other conditions include infective endocarditis, and also when referring to mitral regurgitation, um, another important cause for mitral regurgitation is ischemic heart disease, such as rupture of pupillary muscle seen in myocardial infarction. So the majority of valvular abnormalities involve the aortic and mitral valves. Tricuspid and pulmonary valves are involved much less frequently. The valves may be either stenotic or insufficient, or it can show features of both, and abnormalities can involve only one valve or more than one valve in a certain individual. Next, we will just have a quick look at the factors influencing the clinical outcomes and manifestations of valvular diseases, and these depend on several factors. Number one, it depends on which valve is involved. The manifestations of valvular abnormalities in the left side of the heart, which are the aortic and mitral, may be different to the manifestations of valvular diseases involving the right side of the heart, such as tricuspid and pulmonary valves. Secondly, the degree of valvular impairment. This is quite self-explanatory that if the degree of impairment is mild, then we expect the patient to be either asymptomatic or have only mild manifestations. But if the valve is severely damaged, then the manifestations will also mirror that. The speed of development of the valvular impairment is also important. In general, if the abnormality occurs rapidly, such as that in acute mitral regurgitation as a result of myocardial infarction, versus mitral stenosis that develops over a period of years following rheumatic fever, the manifestations tend to be worse if the development occurs acutely and rapidly. This is because if the development is slow and progressive, then the heart has time to develop compensatory mechanisms and therefore may mask the problems in terms of the patient's manifestations. And that brings us to point number 4, that if the compensatory mechanisms are effective, then again it can also mask the problems and the patient may not have clinical manifestations until the compensatory mechanisms have started to fail. Now let's have a look at degenerative valvular disease. So this refers to changes that affect the integrity of valvular extracellular matrix. And this is an important cause in many of the acquired valvular diseases. The pathogenesis of degenerative valvular disease includes four main mechanisms. The first one is that the integrity of valvular ECM can be affected due to calcification. So calcifications can be cuspal, typically in the aortic valve, or they can be annular. The second mechanism is there might be alterations in the ECM itself that can lead to increase in proteoglycan, diminished fibrillar collagen and elastin. So this is the underlying mechanism to the formation of myxomatous degeneration. And then in some other cases, the valve can become fibrotic and scarred. Okay, and that can also affect the integrity of the valve. The third point is that there may be changes in the production of matrix metalloproteinases or their inhibitors. And the fourth point is degenerative valvular disease can develop as an effect of aging or wear and tear process related to the repetitive mechanical stresses which are placed onto the valves of the heart. One of the commonest acquired valvular abnormalities is aortic stenosis. Aortic stenosis refers to stenosis or narrowing of the aortic valves. They tend to manifest around the age of 70 to 80 years of age. But if the patient has bicuspid valves, then they can manifest a good bit younger than this, maybe around the 4th or the 5th decade. The major etiology for aortic stenosis is degenerative calcifications and aging or wear and tear process, but a small proportion of aortic stenosis develops as a result of rheumatic heart disease. So what we see morphologically, there will be heaped up nodular calcifications as shown by the arrow here on the outflow side of the cusps. So this is us viewing from the aorta. So this is from the top going down. So this is the outflow side of the cusps. And as a result of these nodular calcifications, as very extensive calcifications, the valve cusps become thickened and rigid, and that results in narrowing of the orifice because the compliance is now reduced. The valve does not open as wide as it's supposed to be. So this is what stenosis means. But you can see that the commissures are still preserved. On the right hand side, this is an example of aortic stenosis involving bicuspid valves. So you can see only two valve cusps present here, but the pathology is the same. So what are the important clinical manifestations or complications relating to aortic stenosis? Patients can have several symptoms and signs, and perhaps the more common or important is complaints of anginal chest pain, anginal type chest pain, or syncope, and on examination we may be able to detect the presence of murmur. And complications that can arise in aortic stenosis include left ventricular hypertrophy, myocardial ischemia, cardiac failure, and infective endocarditis. So in the setting of aortic valve stenosis, what happens is that abnormal valve with narrowing of the orifice will lead to increased pressure and workload of the left ventricle, because the aortic valve sits in between the left ventricle and the aorta. So it is the pathway for blood to flow from left ventricle into the aorta. So narrowing of the aortic valve will lead to increased pressure and workload of the left ventricle, and that gives rise to left ventricular hypertrophy. Because the orifice is now narrowed, then there will be significant turbulent flow across the narrowed valve orifice. So this is what gives rise to identification of murmur on auscultation. Another important point is that the abnormal valve predispose to infective endocarditis. surface. There will be vegetations, fiber vegetations with microorganisms and bacteria within it, located on the valves and destroying the valves further, and also comes with another set of complications which we will discuss later. So the narrowing of the orifice, as we mentioned, leads to left ventricular hypertrophy. What is the significance of this? The significance of this is that the hypertrophied myocardium is more prone to ischemia because the wall of the heart is thicker, the myocytes are also larger, so in general this results in an increase in an oxygen demand to the cardiac muscles. So more prone to ischemia, so patients can also complain of angina, and eventually patient may develop cardiac failure. So go back here. Again, we mentioned about the narrowing of the lumen resulting in less blood flowing through into the aorta. So this leads to a reduced cardiac output, and patients can manifest with syncope, for example. Okay, so that's the symptoms and signs as well as the potential complications of aortic stenosis. Another important valvular abnormality is mitral valve insufficiency. And the etiology of mitral valve insufficiency can be divided into three main groups. It can relate to abnormalities of the leaflets and the commissures. It can be due to abnormalities of the tensor apparatus which are holding the valve leaflets, or it can be due to abnormalities of the cavity or annulus. Abnormalities of the leaflets and commissures include rheumatic heart disease or myxomatous valve, which I will describe in a little bit. Now, abnormalities of tensor apparatus is actually quite common because the entities that cause it are related to ischemic heart disease, and ischemic heart disease is very prevalent in our population these days. So an example of abnormalities of tensor apparatus is when there is rupture of the pupillary muscle or the chordae tendineae, and often this is a result of myocardial infarction resulting in acute mitral regurgitation. And this is a medical emergency, and this is an example here where you can see the pupillary muscle is now ruptured. So there is nothing tethering the valve leaflet to the ventricle. So the valve becomes floppy, and that leads to insufficiency. Papillary muscle fibrosis can occur as a long-term consequence of myocardial infarction because infarction in the heart heals by fibrosis, and if this affects the papillary muscle, then you can get papillary muscle fibrosis. Papillary muscle becomes quite rigid and no longer compliant, and that can also affect the valve function. Abnormalities of the cavity or annulus, an important cause is left ventricular enlargement. So when the left ventricle enlarges or dilates, then the papillary muscle will also become stretched, and this will pull the valve leaflets apart, leading to mitral regurgitation. Let's go a little bit deeper on myxomatous mitral valve. In this condition, the mitral leaflets are floppy. Myxomatous mitral valve can be primary or secondary, and the pathogenesis differs because in primary it's probably related to intrinsic defect in connective tissue synthesis or remodeling. This leads to defective extracellular matrix deposition or formation. An example is myxomatous mitral valve arising in the setting of Marfan syndrome. In secondary myxomatous mitral valve, the pathogenesis involves injury to the valve myofibroblasts, which are imposed by chronically apparent hemodynamic forces. So what does myxomatous mitral valve look like? Very striking ballooning and hooding of the leaflet, so it looks a little bit like your hot air balloon, and the valve leaflet will prolapse into the left atrium. The leaflet itself can also be thick and enlarged. As you can see, here is another example of prominent ballooning and hooding of the leaflet. A secondary structural change that tends to occur in myxomatous mitral valve is dilated left atrium. So that is often seen together with the abnormality of the valve itself. So what are the clinical manifestations and complications of mitral insufficiency? Patients may be asymptomatic, but if they do complain of something, they may complain of palpitations, dyspnea, or atypical chest pain. And on examination, expected finding includes mid-systolic click and maybe murmur. Severe mitral regurgitation can lead to left atrial dilation, and left atrial dilation can give rise to several problems, such as giving rise to atrial fibrillation, formation of mural thrombus, and subsequent systemic embolism, and can also contribute to cardiac failure. Okay, so how does left atrial dilation come about? Regurgitation of blood from left ventricle to the left atrium leads to volume overload and dilation of the left atrium. Dilation of the left atrium predisposes to atrial fibrillation, and on top of that, left atrial dilation also causes abnormal blood flow within the chamber, particularly in the atrial appendage. So left atrial dilation and atrial fibrillation taken together are strong risk factors for the development of mural thrombi. And when there is mural thrombi forming in the atrium, some of it can break off and then pass through into the left ventricle and out into the aorta and into systemic circulation, causing systemic embolism and possibly infarcts involving certain end organs. In terms of the abnormal valve, so as we mentioned earlier, any abnormal valve will predispose to the formation of infective endocarditis and all of its potential complications. Okay, the next subtopic that I'm going to touch on is valvular vegetations. So valvular vegetations refer to the presence of vegetations on the valves which may be either infective or non-infective in nature. In infective endocarditis, it is due to microbial infection of the heart valve or the endocardium. It can be divided into acute or subacute, and importantly, the infection is often introduced by the state of bacteremia, for example, during dental procedures. The risk factors for infective endocarditis include the presence of valvular heart disease, so the abnormal valve seen in valvular heart disease, patients with prosthetic valve, intravenous drug user. In this setting, the tricuspid valve is often involved, patients who are immunosuppressed, as well as those with endocardial trauma. Non-infective endocarditis, there are two examples in particular. The first one is non-bacterial thrombotic endocarditis, which is also known as Rheumatic endocarditis. The etiology of NBTE is hypercoagulable states. And another example of non-infective endocarditis is Lippmann-Sachs endocarditis, seen in the setting of systemic lupus erythematosus, and the underlying etiology of Lippmann-Sachs endocarditis is immune complex deposition. So the risk factors for the development of non-infective endocarditis include conditions which are associated with hypercoagulable states, such as DIC, or patients with mucinous adenocarcinoma, hyperestrogenic states. So these can all predispose to development of NBTE, and also conditions such as endocardial trauma, which can provide a nidus for the endocarditis to develop. The morphology of infective endocarditis differs to the morphology of non-infective endocarditis, and the main difference is that in infective endocarditis, the vegetations are large and friable. They're composed of fibrin mixed with inflammatory cells and microorganisms, and there is often destruction of the valve and also the adjacent tissues. So this is an example of infective endocarditis. A schematic example, you can see that the valve is destroyed by this large friable vegetation. Mitral and aortic valves are most commonly affected. The vegetations can be single, can be multiple, can involve one, can involve more than one valves, and if it extends into adjacent tissue, it can also give rise to ring abscess formation. In non-infective endocarditis depicted here in schematic drawing, this is non-bacterial thrombotic endocarditis, and here is Lippmann-Sachs endocarditis. The striking difference between non-infective and infective endocarditis is that the vegetations in this setting tends to be rather small, only maybe around 1 to 5 millimeters in size, and they're generally non-destructive. So here's another look at infective endocarditis. You can see that the vegetations are large and friable, and it sort of takes over the valvular structure. So it's destructive and it destroys the valve. And here on the right hand side, we can see that the inflammation and destruction of the tissue has involved the myocardium and leading to ring abscess formation. In contrast, the vegetation in non-bacterial endocarditis is really quite small, and they're just arranged along the valve leaflet. The structure of the valve itself remains intact, and there is no destruction of the valvular structure. But these vegetations have the potential to break off and travel into the systemic circulation and cause embolism. There are several complications that can arise in infective as well as non-infective endocarditis. The complications of infective endocarditis include glomerulonephritis as a result of immune complex deposition. Patients can also get septicemia and arrhythmia, and perhaps one of the most common as well as serious complications resulting from systemic embolism, because the vegetations on the valves are large and friable and tend to break off easily, and that can form systemic embolism. Because the embolic material contains microorganisms, then the outcome often results in septic infarcts as well as mycotic aneurysm formation. So in addition, local complications include valvular destruction, and that can lead to valvular insufficiency. Patients can manifest in various ways. Fever is one of the more common manifestations. They can have chills, weakness. They may have murmur due to presence of agitation. And then another clinical manifestation is that relating to microemboli, which are thrown off by these vegetations, and they go everywhere and anywhere, and these manifestations include petechiae, splinter hemorrhages, retinal hemorrhages, etc. For non-infective endocarditis, the complications are rather similar. They can get systemic embolism, but because the embolic material are sterile, then they do not result in septic infarcts per se or mycotic aneurysms. However, there is a risk of developing infective endocarditis on top of existing sterile vegetation. So you can get secondary infection of the sterile vegetation, and then that leads to infective endocarditis. And if that happens, then all the complications of infective endocarditis here applies as well. For Lippmann-Sachs endocarditis, there is a potential for development of fibrosis and deformity of the valves. So the valve may develop sort of a chronic structural change in the future, such as stenosis, etc. In terms of manifestations, patients may be asymptomatic, or manifestations can relate to the development of valvular dysfunction, infective endocarditis, or embolism, as we had discussed earlier. So for a quick recap, we had talked about the major valvular heart diseases, which are stenosis and insufficiency. The most common valves affected are aortic and mitral valves. these valvular abnormalities can be congenital or acquired. The morphology of the valvular abnormality depends on the pathology itself, and the clinical manifestations are influenced by several factors, as we had discussed, and also illustrated by the entities aortic stenosis and mitral insufficiency. Then lastly, we talked about the valvular vegetations, in which can be divided into infective or non-infective endocarditis, and they differ in etiology as well as morphology and potential complications. My references for the lecture are Robin's Basic Pathology, the latest edition, as well as Underwood's Pathology, latest edition. See you in part 2. Thank you.